It's a very good initiative, and I think it breaches the bridge between clinicians and patients very well. Okay. So today's talk, I would like to outline briefly what we're going to go through. So the first thing is we'd like to go through some statistics, just 1 or 2 slides, okay, to have an idea what we are dealing with. Then the impact of these statistics, another 2 or 3 slides. Again, refreshment of the diabetes definition. What exactly is diabetes? Okay. Then we define diabetes self-management education and the mode of delivery of educational programs such as we have seen in the previous presentation. And the learning objectives hopefully would be so that you can better understand diabetes, okay? You can understand how to monitor your condition. You get knowledge about medications and how to adjust them, how they work, if you take them before meals, after meals, what is the half-life of each medicine. You have to understand these things. Knowledge about the complications and how to prevent them, okay? And finally, how it impacts the quality of life. The best statistics that I found was to quote the IDF. The IDF, last published in 2021, was the 10th edition. And it gives a very, very clear picture of what the global situation is as regards to the incidence and prevalence of diabetes. So most interesting is that, if you can see up there, there is the data which says about 537 million people currently have diabetes, okay? Interestingly here, you can see that there is an equal number of 541 million people who have impaired glucose tolerance. Now this definition has changed and now we call it pre-diabetes. And that is, you are diabetic, yes, but you don't fill the full criteria for diagnosis, but you're there. Your metabolism with glucose is not exactly as it should be, so we're using the term pre-diabetes, okay? Eventually, if you don't take any measurements, you will develop full-blown diabetes. And that's another terminology for that. The amount of money spent on management of diabetes worldwide, the number of deaths, and also the predictions, what is projected. You can see here that 643 million people by the end of 2030. So it's quite a problem actually. And if you look at Malta, because this is our main interest, the latest published data show that by 2030 we will have something like 57,000 people with diabetes. At present we are dealing with something like 39,000 patients. Roughly 22% of the population is obese and the further 36% is overweight. That's among the highest we can get in Europe. About the data of how much we spend, it's a very difficult area. People who work, I have my colleagues here, people who work on how much it costs per patient, it's a very tedious and difficult. I found things like 5% of the health budget, others quote 11%, so I didn't want to put it down here, but we're roughly there. A huge amount goes for chronic diseases, and diabetes is one of them. Now, the first question is, what is the impact of these statistics on diabetes care? Okay? So, accessibility to healthcare services. Now, all patients who have diabetes are under some form of program. They attend their clinics, and if, for example, according to international guidelines, a patient with diabetes would be served ideally if he has at least 2 visits per year by a consultant and another 3 visits by his GP or nurse practitioner. That would be the ideal. But if you have so many patients, so huge numbers, you are going to impact the frequency of those visits. And also the time. Ideally, again, we should spend at least 20 minutes to give a good service to a patient with diabetes. Okay? It's not just coming in, looking at the blood glucose profile, telling him that it's okay, continue same, see you 6 months' time. That is not the ideal service. Okay? You have to listen to him or her. There are needs. It's extremely important. You have to look at the impact of quality of life, and that in a good setting will take you about 20 minutes. That is a good service. But again, if the numbers are continue to increase, then we have huge problems. Again, the human resources, dietitian, education services, you have to cater for all that. Then there is an impact on the complications. The more patients you have, okay, the more numbers, the more people you have with diabetes. There is an impact on the frequency of the visits, so you get more risks as far as cardiac events, nerve damages, retinal damage, because you don't have people who are being screened so often, kidney failure, and a lot of infections. Okay? And that comes, remember that patients with diabetes after 10 years start to develop risks, whether we like it. These are statistics. But if you have a good service, that complication risk is reduced to a very, very minimal percentage. Okay, you can actually do it. And then the expenditure on the health service, as I said, in general, it is a burden, but how much it is in Malta, I beg you to understand me that it was difficult to get the exact figures. And it's best not to quote anything rather than quote something. Okay? And now the question is, how can we address this ongoing and increasing global problem? Okay? So we have to consider support and improve the issue of self-management. And this is the issue, the main topic that we are discussing, self-management, okay? So that we may slow the progression of this condition and also prevent acute and chronic complications. As I said in the beginning, if you know what you're dealing with as a condition, and if you're part of a team where you can contact your healthcare professional, okay, you can know a lot and become an expert. Forget diabetes for a time being. Let's say hypertension. If you know why you have hypertension, a little bit of the causes of hypertension, what medications you're taking, how they work, you can self-manage. But you need somebody to help you as well. And diabetes is the same. Okay? You have to identify where are the gaps in the existing system. So if there's a system and it is not providing for accessibility to address patients' needs, then you have to identify it and try and correct it. Look at the needs of the patients with diabetes, we've said that, and resources, the use of technology, as we've just seen, that it's a very important, okay? And here I also want to stress, it's not just use of technology vis-a-vis websites, also how to use things like the glucose monitor, how it works, okay? And also, for example, continuous glucose monitoring rather than frequency, okay? Exploring models of care in diabetes. Now, that actually is important because in each situation, you have a different healthcare system. Each country has a different healthcare system. And it's not what you would like to have, but it's what you have and what you would like to make it work. Okay? And these models are there to help us so that we can apply them to different chronic diseases. I will show you a little bit. It's not difficult to understand. I will keep it very simple. But the concept is this. You have to have a model so that you can actually collect all your services and implement them so that you get a good outcome. All right? It's used as having 10 different organizations doing their own thing, but they are not in a model. Okay? And one of the things in diabetes which works is the NGOs. The NGOs are extremely important, not only in diabetes, but in other chronic diseases. They do a lot of work, and they are a good right arm of any healthcare professional. We need NGOs. So how do we define diabetes? The idea that you don't develop diabetes by eliminating any source of sugar from your diet is false. Okay? You need sugar. A diabetic patient needs sugar. Without sugar, the diabetic patient cannot survive. It's not a paradox. It is the science of it. Okay? So even if you are diabetic, you can't stay without glucose, you can't stay without sugar. You have to have it. Otherwise, your cells cannot function. We're talking about brain, heart, lung, liver. Nothing can function without glucose. So the problem is this. It's a chronic progressive metabolic disorder characterized by hyperglycemia, that we know, mainly due either to an absolute deficiency of insulin, where you don't get insulin at all since birth, we call it the type 1, or a relative. It means a relative deficiency of insulin, where because of either a bad lifestyle, either because of age, or a predisposition for the pancreas to undergo what we call apoptotic cells, to undergo a death process at a certain age. It was predestined. Okay? For some reason, the insulin is not being secreted. So the defect is not the glucose, it is the ability to use insulin to be able to metabolize your carbohydrates. That is diabetes. Okay? It affects every system of the body, mainly due to the metabolic disturbance caused by the hyperglycemia. Okay? The longer the glucose is not metabolized and stays in your body, the longer the toxicity to the cells, okay? Because that is converted to a form of an acid. We won't go into it, but that is the longer it takes to be metabolized, the more harm it will do to the cells. So what are our objectives now as healthcare professionals when we manage a patient with diabetes? To relieve symptoms. What symptoms? Hunger, weight gain, tiredness, lethargy, frequency of urination, psychological problems, depression, problems with the sexual health of the individual, and extremely important, but we don't talk so much about it. It's very important. These are all symptoms which we as healthcare professionals, and when I say we, not only doctors, and qualified nurses and other healthcare professionals, okay? To correct associated health problems and to reduce the morbidity and mortality from the condition. To prevent as much as possible acute and long-term complications, and to improve the quality of life and productivity of the individual. So a question arises, can I have a good quality of life if I am diabetic? Of course you can. And another question, if I follow the steps of number 3, can I reverse my diabetes? Again, these two questions have been answered. The first one was a very good study published 2.5 years ago in Newcastle, where now the question has been answered. A good lifestyle in patients who are diabetic can reverse the condition in some patients. Okay? Now, some patients, there are thousands of patients, but the majority can reverse it. And another question, if I am already taking medications, can I actually end up not using the medications? Again, it's another yes. So all these things are important for you to know. They're not something which I can keep for myself, because they motivate you. So this is the problem with self-medication. You need to know facts, because then why are you doing it? You do it because of this scientific data. And the interesting thing about that Newcastle study was basically that they found that the pancreas collects fat within the cells and squashes them. So a good lifestyle will remove that minimal amount of fat from pancreatic cells and it regains function. This is what it's all about. And you have to lose something like 15 kilos. Okay, so you can appreciate the importance. Now, so what is self-management now? Self-management is an intervention that involves active patient participation in self-monitoring or decision-making with the application of knowledge and skills. So you have to have the knowledge about the condition and skills. Now, what skills? We're not talking about surgical skills. We're talking skills about how to use a monitor, how to correctly measure your blood pressure, and things like these. Okay? Those are the skills that we are talking about. Now, that was the general definition. If we applied it to diabetes, this is the correct definition that we have to follow. It's a shared program through which people with diabetes are given the knowledge and skills. They need to be able to modify the lifestyle and successfully self-manage their diabetes. This shared process looks at the needs of patients with diabetes and their experience with the condition, and it is an evidence-based program. Another word that we use, you've heard it so many times. To give you a definition of evidence-based, it's a bit difficult. The terminology that they use is it's very statistical. But in simple words is this: whatever intervention or process you use, if it's evidence-based, it will work. That is just a line. But behind it, there is a whole lot of terminology. So if I, for example, give this particular treatment, I know that particular treatment is evidence-based and it will work. So what knowledge do we give patients? Okay? So empowering patients through self-management and education improves the glucose control, again, evidence-based. The A1C and renal profile. A1C is the hemoglobin, which is attached to glucose molecules and stays attached with them for 3 months. So when it comes to assessing your diabetes and you ask, am I being well controlled? Usually we use the A1C, the glucose, which is attached to red blood cells. It gives you a 3-month idea of how you have been performing. Okay? It's better than the fasting. Okay? Because the fasting, you can play with it as much as you like, but the A1C, you cannot. It's as simple. The quality of life. Again, we said that patients with diabetes should not have a different quality of life than patients without diabetes. There's no discrimination. With the knowledge that we have today, okay, there should not be any problems. I have colleagues of mine who are surgeons, who operate, who are diabetic, but nobody knows. They have a good quality of life, and they proceed in life and proceed with their career as much as they can push their limits to. Cardiovascular fitness, weight loss, preventing acute complications. Again, we touched on that. How can we improve it? By good control, reducing the risk of long-term, the psychosocial behavior, and early referral to a specialist. One important thing about the technology is that if you are part of a group, okay, we can identify those patients who really need a specialist, and they can be referred earlier. But that you need a relationship between the primary, secondary, and the community. That's how it works. Now, how it can be delivered? You can have multidisciplinary teams. You can have group sessions, one-to-one. You can have structured courses. My colleague will talk about those. And the chronic care model. Now, all these three are good, but we noticed that whenever we try to set them up, especially through primary care, they work for a few months and then, okay, people do not attend anymore. They are difficult. I know what the reason is. I don't want to criticize so much, but the reason is that you have to work in collaboration. You cannot do it on your own. So we had a program, for example, where the healthcare professional and the nurse practitioner would invite and give lectures every week. Okay? But it can't work on its own. The patient, if you don't involve him, he's not going to come to us and hear us talk. He has to be involved, and that way it will go down. So that's why the education is important. Now, finally, let's go to the chronic care model and the structured courses. These are courses which they do abroad. It takes about a year, and they give you a certificate at the end, which is motivational. That's good. The chronic care model. Now, what it does is this. So it explores what is happening in your healthcare setting. Okay, so it goes in the community, the health system, the self-management support. It looks at delivery systems, decision support, who does them, and the clinical information. Okay, and all these components, these 6 components, are integrated in a service, and they assist in the organization of care provision to involve patients in the management of the disease. And this is what you get. So, nothing difficult, so you have the community where there are the resources, the healthcare policies, okay? The health system, primary care, secondary care, where they are delivering the clinical information, the decision support. You get all those together, you get an informed, activated patient, this is important, prepared, proactive practice team, and together you get an improved outcome. And that is the care model, and this is applied to across the board, not only to diabetes, but through everything. See, and it's nice to see that patients are involved. So the patient becomes knowledgeable and the expert in diabetes. He understands the importance of taking control of his or her diabetes. Also, it involves the patients have relatives and friends, and don't forget them, who are important to them and their management. And the provider includes them as the patient desires. We need to talk to them as well because they are part of a family. It's not just the patient. So, and the provider will take time to build a relationship between the patient and understands their beliefs and values. Okay? So in summary, regardless of the healthcare setting, the processes of communicating the information and supporting skills to patients with diabetes have taken a more personalized and comprehensive approach. Okay? Effective delivery involves experts in education, clinical, psychosocial, and behavioral areas, a patient-centered approach to DSME and diagnosis provides the foundation to current and future needs. However, this is a little bit discouraging. Despite proven benefits and general acceptance, the number of patients who are referred to and receive DSME are disappointingly slow, as I said in all major published studies. So it's not only in Malta, it's everywhere else. We need to work on that. Okay. Now I just like to ask you, how am I going in time? Because I can either stop and then...
I think that would be ideal if you stop with that, Mariel, and then we take questions.
And then we take questions. Okay?
Very
good. Thank you very much.
Thank you.